And looks like we are all muted. Fantastic. Well, welcome everybody. Very exciting to be able to present a brand new element of our Juniversity programming called Harzian Temple Talks, sort of fashioned after the TED Talks. And we are showcasing the many incredible and interesting and wonderful members that we have in our congregation who do things that are just fantastic, and we don't necessarily get a chance to hear about those things because it's their regular life as opposed to their temple life. So we are sending off the series with Dr. Alan Landay, and he's going to talk about what he does with medical research. He'll introduce that himself. But the way that these talks are going to be presented, we have themes for each month in the Juniversity programming, and the themes for February were character traits, and specifically character traits that can lead to behavior and activities that can, quote unquote, save the world. And so nobody would be more fitting as our first speaker than Alan Landay to talk about his work with medical research. So we are, the format is going to be a presentation for about 25 to 30 minutes by Alan, followed by 10 to 15 minutes of questions and answers. And we're going to ask that you put questions into the chat window. And if you don't know how to use the chat window, at the bottom of your Zoom screen, there are a number of icons. And in the middle of the screen, it says chat. If you click on that, it opens a window which you can move around on your screen, and then you can type into the window and send messages. So if you send the messages to everyone, we'll all see them. If you want them to be private, you can choose who you send them to. So you can send them to Temple Harzian, which is me, and then I'll pick and choose some good questions and pass them on to Alan, and he'll answer our questions. So without further ado, Alan Landay.
Great, thank you, Charles, and it's really a pleasure to be on the inaugural Juniversity Temple Harzian talk today and this month. I really feel very honored to be chosen for this, and we'll talk a bit about my journey, and I think having a prepared mind to work in the field that I've done. And I'm going to take you back on my journey some 40 years ago back to Birmingham, Alabama, where I started my career in HIV in 1981, so 40 years ago, which was at the very start of the HIV epidemic at that time. And I call it an epidemic because it did become a pandemic ultimately, but we really just started back then with describing the first cases. And those of you who may not know, the first cases of HIV were described in Los Angeles, in New York, and Washington, D.C., and they were published under the Centers for Disease Control. We've heard a lot about the CDC today in the SARS-CoV-2 COVID-19 era, but I'll talk about the early days. I did work with the CDC around HIV. At that time, it was a disease in predominantly gay men. And we actually, in 1981, when the first papers were published in a very prominent journal, the New England Journal of Medicine, did not know about the cause of that disease. And we didn't know it was an actual virus that caused HIV. It was actually called GRID, Gay-Related Immune Deficiency Syndrome. So that was the first name that this new disease had in 1981, before we knew anything about a virus. We then found and called it acquired immune deficiency syndrome. And I was working in a laboratory of a world expert who had worked on immune deficiencies, but those that were inborn, that were mainly found in children. And his name was Dr. Max Cooper, a very famous immunologist. So I was trained as an immunologist. So I came to this field of research and study as a clinical immunologist. And what happened one day was a hematologist in 1981 came in the lab, and they just heard that this new disease was not only affecting gay men, but also in hemophiliacs. and it became very important. There was a large clinic for hemophiliacs who were getting their factor VIII to replace their clotting factor that was deficient in the hemophiliac population. And they were getting this same immune deficiency disease. And that was characterized by the loss of a particular type of immune cell. And that immune cell was called a CD4 T cell. You may have heard more recently about the immune system in COVID, about antibodies and T cells. So we were studying that back then in our early days, and found those cells were lost in this population early on. So we actually did the first studies in Birmingham, Alabama in 1981-82 with this disease in hemophilia. And it really allowed us to understand and characterize that disease. I think some of the other more personal moments in Birmingham, it was the South. I mean, it was the South of George Wallace. George Wallace was still alive. I worked in the Lorleen B. Wallace Tumor Institute, named for George Wallace's second wife. I met George Wallace one day when George would come up in his wheelchair. You remember he was shot and was in a wheelchair for most of his life. Many of you may remember him and having seen him in the early 50s and 60s. And he rolled up in his wheelchair one day, and he would have, as he said, a talking to you if you were planning on leaving the University of Alabama or his namesake university or institute. And the director of the institute was planning on leaving and going to University of Pennsylvania. It was unheard of that anybody would leave this wonderful bastion of research at the University of Alabama, Birmingham, and move north. And so George Wallace literally came in and talked to the director, and I saw this and was party to this going on at the time. It was a very fascinating period in our history and seeing how the South was. And it really was the South. I was on radio talk shows back then, 40 years ago, listening to people that this was the gay men, that they deserved what they were getting. And again, the whole of the field of HIV and all of the how people felt about working with this disease, especially that this was God's punishment to the behavior of this population. I was listening to people come on the show and ask me how I could work with this. So I really got, and I was only, in 1981, I was 26 years old. I was a young postdoctoral fellow hearing all this. And it was just very shocking to me as a scientist to learn all this firsthand and really have that experience. And I think that's kind of shaped me. And it was really an opportunity to learn science, but also learn about the impact and how people were treated and the social and moral values that people have. I think that also helps shape the way I think about things today and helping people and doing more. I moved to Chicago in 1983, and that's really an important time when we began to understand. In 1983, we discovered that there was a virus that was a cause of this disease, and that was known as the human immune deficiency virus. So people hear about HIV/AIDS. HIV is the virus that causes the disease. AIDS is the disease itself, the acquired immune deficiency syndrome. So this, again, early days, we were just finding that there was a viral etiology, both in the gay men, in hemophiliac and drug addicts. It was also the beginning of seeing this in children and other populations around the world. So it was very early on. And I was actually able, when coming to Chicago in those early days, to work with a local company, the diagnostic company, Abbott Diagnostics, and actually work to help to develop the first HIV test, antibody test, that was used to then screen the blood supply. And this test was licensed by the Food and Drug Administration in 1985. So there was a great opportunity to see and work and actually develop as an academic young assistant professor at Rush University in Chicago. How do we go through the process of licensing a diagnostic and working and what goes into this? And this was at the earliest time, and having such a huge impact that once this particular test was licensed, it really helped use and screen and protect the whole of the US and the whole global blood supply at that time. I also remember hearing from the health and Health and Human Services Secretary, Margaret Heckler, who was at that time in 1985, in which she announced, she said, within a year, we will have a vaccine for HIV/AIDS and it will be eliminated. That was stated in 1985, over 36 years ago. And here we are still today living with this as a chronic manageable disease, but we're still living with HIV and AIDS. We know there were very significant developments further on down the line in the later 80s for new drugs. And I was talking to Charles earlier about Matthew McConaughey and his movie, the Dallas Buyers Club. That was earlier than when there were no drugs. This was at a time when people were looking at all these newer drugs that may or may not have had an effect, and things that you had never heard of before. Treatments for people like Rock Hudson, you'll remember, who came out and was found to be HIV positive. And it's when these very famous and well-known people came out in the community, there was a little more acceptance perhaps to having this new disease and understanding more about it. The first of those drugs was called AZT. It was a drug that attacked the virus, one of its actual proteins that's involved in its replication. And that was a drug from GlaxoSmithKline. So that was our first drug. It wasn't until 1987 that the FDA licensed the first drug, and we were able to work on that. And then when we developed newer drugs and better drugs, it was in 1995 that the best impact happened. And I was at a meeting in Vancouver, Canada, when this new announcement came of this new class of drugs that were called highly active antiretroviral therapy, or HAART. That changed the whole way in which we treated HIV and changed our whole outlook on the disease, and really made us advance where the whole disease mortality and morbidity was reduced greatly. So with new drugs came better hope for the patient. In those first years, when we studied HIV in the 80s, all the way up until those 90s, people would become infected and they would die within a matter of weeks or even months. It was a horrific, it was a death sentence. And people would just actually sign their wills when they came to see their doctor. And I saw this firsthand at the hospital and with colleagues around the world. But it was in the 90s that we changed the whole face of this disease and had these new drugs. And up until today, some 25 years later, we really were able to look at this and understand now that we've got where there were multiple pills that people took. And I think many on the calls today who've taken care of patients or worked with AIDS patients would know in those early days, they would have to take 10 to 12 pills a day. And those would have to be much of their medicine refrigerated. And what changed that today in 2021, we have one pill once a day. And you may see many of these ads on TV for the AIDS drugs that are there. And now we can treat patients globally. We found out that HIV is really a global disease. When we started in our early time in those 90s, we didn't really recognize about what was happening in Africa. It was a real unknown. No one knew about Africa or the impact of this disease. And when we went in and we were able to now open up with the people at the NIH, and you know who one of the first people to make and recognize that this was a name that's a household name to all of you today because of COVID, Dr. Anthony Fauci, Tony Fauci, who you all probably know his name well, having listened to him every day on the news or watching him on every Sunday morning or in the newspaper. He was the one who made us recognize how important the other parts of the world were and this pandemic was in terms of HIV. And really, it was in those early 90s that we went into Africa and we were having meetings and recognizing that most of the HIV infected populations are in Africa. Almost 95% of today's world AIDS population are in Africa. We have 1.7 million cases of HIV in the US. We have 37 million in Africa. So just think about that. What we have today in terms of the cases of COVID-19, this is this morning's statistics I got off the Johns Hopkins website. Today's statistics for the numbers of cases of COVID-19, 28 million as of today in the US. So you can see there's a huge number. And globally, we have 111 million worldwide cases total, whereas we have over 40 years, we may have reached that number of HIV. So it's really daunting to think about the differences that we've worked on. We also have known as the disease has changed, we've also realized how we can take care of patients. And it's now become a chronic disease, a disease of aging. I actually moved my department to go to a division of geriatrics. And now in 2021, HIV is a chronic disease. It's a manageable disease, one in which people are living. Most of those million people in the US are over 60. Whereas when I first started studying HIV in the 80s, they died in their 20s and 30s. These are people now that are living into their 60s and 70s and almost a normal lifespan on the current drugs. What are HIV patients dying of today? Heart disease, they're dying of diabetes, the chronic diseases we all die of in our 80s and 90s. And that's really an amazing feat to see how we've been able to do that. We're also working on HIV prevention. We now have the same drugs we've used to treat HIV, we're using it to prevent in our populations. And the populations affected are not so much the white gay men that we saw in the early phase. It's predominantly in the African America and the Latinx community, the same communities that we find COVID-19 and SARS-CoV-2. So there's still a lot of the similarities between the two of these epidemics and pandemics together and how we look at them. What I'd like to do is to move on and talk a little bit more about SARS-CoV-2 and its similarities. If Charles could put up a few slides. So my 40 years of HIV, Charles, has gotten me and learned a lot about how we can now move into this new pandemic in the US. And I'll just go to this slide. So I just want to show you what Rush has done. This is what happened at Rush back only a year ago. So we knew a lot about a COVID response was huge. In the left hand up here, this is our room where command center. We had 50 to 60 people in here. Now you're going to say, wait a minute, you're not socially distancing and people aren't wearing masks. Well, ultimately, this was back before all of those recommendations were being made. This actually picture was stood up or taken at the very beginning before we knew that. These tents look like MASH tents. This was in our emergency room bay where we stood up MASH tents for actually testing for SARS-CoV-2. And then we had drive-through testing. This is somebody who's doing a nasal swab. And this is our emergency room stood up for patient beds. And this is in our hospital now, where we have now 2 beds split in one area. On the next slide, I'll just show one other. We also had a huge community impact. We tested a lot of the first responders for SARS-CoV-2. Also at Rush, we're working with the homeless population, a lot of the African American and Latinx on the west side where Rush is and Cook County. We tested over 2,000 individuals and found a huge rate of positivity, 10 to 50%, much greater than the overall rates in the US, which are well below 5%. And we started the first COVID isolation center for the homeless. And then we were asked to participate in a rapid response. So if you could turn off the slides. We've done a lot and learned a lot from our experiences in HIV. The first drugs we used to treat our COVID patients were HIV drugs. They were the same protease inhibitors I just told you that changed the face of how HIV AIDS patients did. They were used to test in our COVID-19 patients. We also stood up a number of other approaches like our rapid testing, and many of the same companies, including Abbott Diagnostics, which stood up the first of the HIV test, stood up some of the first COVID-19 tests. It was that same group at Abbott I had worked with 40 years ago that I now work with today on a daily basis, standing up rapid diagnostics for COVID. And we're now not only doing those for patients when you get nasal swabs, but we can do those as point of care tests where you can get a test result in less than 10 minutes over time. So a lot of advances have been made. We've also done a lot to look at vaccine responses. And this is very much in the news today about COVID-19. You can't pick up a newspaper or turn on a Sunday morning. I was listening today to Michael Osterholm from Minnesota on one of the PBS shows, all about vaccines. Should you get one vaccine, or do you need both to get protective immunity? But those vaccine candidates, both the Pfizer and the Moderna vaccines, those are RNA vaccines, something you may not have heard of before. Where did those vaccines come from? They were first pioneered in the HIV field. What about the adenovirus vectors from AstraZeneca and also from Johnson & Johnson? Those are also vaccines that have been used extensively and tried in HIV. So a lot of what we learned, and I learned in HIV, I'm applying now in COVID-19, looking at a variety of things about predicting how well people are going to do and so on. Now, 40 years, we don't have an HIV vaccine, but within 1 year, we had a COVID vaccine. Why is it? Well, we hear about variants of the COVID virus or SARS-CoV-2, but HIV mutates and changes much greater. If we look on a scale of 1 to 1,000, we'd look at HIV variability at 1,000 and the SARS virus at 1. So there's a greater degree of heterogeneity in HIV, making it a very hard target to actually develop a vaccine. The antibodies, which we tried almost 30 years ago against the HIV virus, don't work well in vaccines. Then we moved to T cells. We're still trying to do both, but we're not there yet. So we're still trying today, some 40 years later, to find an HIV vaccine, but that virus has been very difficult. We know that the AIDS virus remains in the host. We don't cure you of HIV, but you can live with it. And we have had maybe 1 or 2 people cured. The original person called the Berlin patient, who was Timothy Ray Brown, who literally had to go to Europe to get his bone marrow transplant and could not come back because, if you'll remember, over about 20 years, they would not let HIV subjects back in the US, and they could not get a visa to come back until the Obama administration. Interestingly, the HIV meeting was not held in the US for almost 20 years because of that restriction for HIV patients being unable to come into the US. So there is tremendous stigma that existed over the Reagan administration era, over the Bush and so on. Although they did great things like PEPFAR and building, it wasn't until, actually, I made a mistake. It was actually Clinton who was able to get the first AIDS meeting back, not Obama. But it wasn't until the Democratic administration back in the White House that we were able to see some of that HIV stigma go away. And it was really Tony Fauci in 1987 who first brought in the HIV activist into his office at the NIH and said, I want you to be part of this solution. He was really prophetic. He has done a phenomenal job in building the HIV infrastructure for us, and has done the same for as a person of reason and rationality over the last year in helping us with COVID-19. So we've made great advances. We've really developed a lot of opportunities over the last 40 years in the HIV pandemic that we're now applying in the COVID-19 pandemic. And what I do every day is I go into the office and try to figure out what is the next big thing that we're going to have to deal with COVID. It's going to be with us for quite a while. We know the variants are there, and we can talk more about that in the questions. But what is it that worries me the most? It's what we call long COVID. What happens to the patients of COVID, of SARS-CoV-2 or COVID-19 when they leave the hospital? Are they still going to have symptoms? And the answer is yes. You may have heard of the COVID fog, the neurologic problems, cardiac problems, problems with diabetes or metabolism. They're going to have things what we may have called chronic fatigue syndrome. We have a major grant at Rush looking at that in the post-COVID era of chronic fatigue syndrome in our COVID patients. But it's not just the most significantly ill patients who come out of the intensive care unit. It's also people who actually have COVID and stay at home for their entire course of disease. Many of them we're seeing have long COVID now. And so that's one of the areas that I'm focused on in trying to put together a group and a team, not just at Rush, but across the US and across the globe. HIV has taught me a lot about global communications and global collaborations. We've lived, and my wife will tell you, we've lived in San Francisco, we've lived in Los Angeles, we've lived in Sydney, Australia, we lived in Utrecht in the Netherlands, and we've lived in Stockholm over the years to really carry out research on HIV. And what it's taught me now, I've got a community of global friends and partners that have helped in developing these approaches to helping deal with making HIV a chronic disease. And many of these same colleagues and friends are with me as well, working towards making and dealing with COVID-19 and hopefully dealing with it so that it won't be this issue that we're seeing today and having to deal with all of the attendant problems of social distancing and not being able, as many of you and us cannot see our children or grandchildren, or if you're younger and want to see parents or grandparents. These are the difficulties we're all facing. So there is a lot of social isolation. That's why we're on a Zoom call today and not in person. So I've learned a lot. I think we've done quite a bit, and I'm going to just stop here so we can have time for questions, because I think people may have a lot of questions or thoughts about this. And thank you, Charles, for inviting me for this first inaugural event, and it's really a pleasure.
It's been our pleasure to hear you talk. I'm going to start off the questions by I'm going to ask one of my own combined with one of the questions that's come in. And the question that came in is, what's the biggest unknown about COVID-19 and what will we need to understand it? And my question was, what are your recommendations for how we need to change the way basic research is done in the private and public sector in order to be ready for future pandemics?
Great question. We're already starting that. One of the other projects I'm undertaking right now is to look for as a Sentinel site. So what we want to do is, how do we prepare for the next pandemic? And we want to develop that by using sites around the world. So we're developing global partnerships with folks like the Bill and Melinda Gates Foundation, with CDC AIDS Africa, with companies like Abbott, and other pharmaceuticals, so that we can now begin to look and identify the clinical unknowns. What happens if somebody has a clinical disease at our own institution and we go in and see we can't diagnose an infection? So then we can start to work with people known as virus hunters. So we now have new colleagues and new friends that we're going to be working with who are part of these teams of virus hunters trying to find that new virus and new opportunity. So that's exactly what we're doing, is to set up collaborative networks across the globe. And almost every country in the world and every group I talk to every day. I was just on the phone this morning to Ireland on this very topic, where we want to collaborate with a pandemic preparedness future effort for the country of Ireland. But we talk with Canada, Australia, everywhere in the world. So we are starting that now. And what we might be able to do is use unique technologies. We actually have a grant with the National Science Foundation that we're using what's called an e-nose, so that when a virus infects a cell, it gives off kind of a scent. It gives off a certain amount of a metabolic scent that we can then actually identify using electronics. Now, if we can perfect that, then when we can actually use these sensors, we can put them in our airports. That's something we've actually thought about and are thinking about, new technology to put sensors in airports, so that when you get off the plane and you may not be feeling well, there may be metabolic products that are given off that'll be sensed. So an alarm goes off and I don't know if you'll be whisked off to some dark room somewhere, hope not, and never come back. But anyways, that's what we're looking at, is these novel sensors, and working with our engineers. We're working with Illinois Institute of Technology locally to come up with these novel sensors, and funding from the National Science Foundation.
Fantastic, thank you. We had a question. Actually, the first question came from Cindy Bernard, and she says, in the 1980s there was tremendous fear among clinicians and researchers related to working with HIV and patient specimens, and she asks, can you speak to that issue of the fear and emotional impact of being a researcher with potentially dangerous specimens, both in the 80s and now?
Absolutely. That's a great question. Um, Maybe I could start by saying, Susan, ignorance is bliss. And luckily, when I first started working in the lab in 1981, I was culturing virus. I was getting patient specimens, but I didn't know there was a virus there. I did learn over time. And even up until now, there was, again, a lot of fear, and people would shun the populations. You're absolutely right. Even today, there are people sometimes will shun people if you find out, will if somebody says to you, they come to your home and you find you don't know that they have HIV or AIDS, and then you give them, they come to your home for dinner, or your friends, or whatever. This is still an issue today, and stigma still exists. I don't think we've ever overcome that stigma, even 40 years later. It is really amazing to see that in terms of, and many of our populations that are most impacted are the most marginalized in our African American and Latinx communities. So these are things that we're dealing with. Now, in the laboratory, yes, I can protect myself. I wear protective gear. I know what kind of isolation I have to do. We put all that in place, and I feel completely safe in that regard. And in the early days, when people would stick themselves with needles from HIV patients, we would test them, and we'd be able to go through that. But we're talking about human beings, and we're talking about the rest of society. And I know we all understand that we're a very open and hopefully understanding group here today on the call, but there are many people around the country who aren't so open and understanding, and we still see that stigma that I experienced back in 1981 in Birmingham, Alabama.
Yeah, thank you. So somebody followed up on your talk about the sensors to say that they saw a report that dogs are now being trained to detect COVID at airports and other places, and we've seen that before with cancer, right?
Yeah.
Where they can detect cancer. So can you talk a little bit about that?
Yeah, I know they're doing it. I've seen it in the news. Yeah, absolutely. I think you're absolutely right that dogs have been trained to detect cancers, and now COVID as well. I think it's phenomenal to be able to do this, and be able to have opportunities like this. And we have such great technological advances today that I think, and I don't want to get into politics today, given the COVID-19 pandemic began under a certain administration, but I'm very happy to hear where we are today with our new administration. And again, as you can tell, I have a great deal of respect for people like Anthony Fauci and others who really now are leaders in helping us get through, as well as the head of our CDC as well. So I think the new leaders in place will really guide us and do a tremendous job in helping to get this pandemic under control in the US, especially with vaccines going forward.
Wonderful. We have a question from Morris. He asks, is COVID-19 basically an inflammatory disease, and how is it different from AIDS?
Very good. Morris, beautiful question. That was my last grant. I can ask you to be my reviewer, and since you understand this so well. It is actually, yeah, it's inspiring to hear people that. I didn't mention about inflammation, but that's exactly right. HIV today, my last talk that I gave is called Inflammaging. And that's what happens with HIV. It becomes an inflammatory disease. And where is the source of inflammation? It's the gut. And it's something that you may have heard about, leaky gut. As you get older, your gut becomes leaky, and the products and the microbes that live there, your microbiome, there are products that come out into the circulation, and they can activate the immune system and cause the disease of aging, cardiovascular disease, pulmonary disease, in HIV. And a lot of that is now we're targeting that with new therapies. Now, what about COVID? Well, COVID is an inflammatory disease of the lungs to start with, where the virus comes. But COVID also gets into the GI tract. And the last grant I wrote, which is I'm being very truthful, was actually looking at the gut-lung axis, that COVID in the gut is the source of inflammation that then causes cardiovascular, metabolic, and even lung disease somewhat. So there are a lot of parallels there between COVID and HIV that we're looking at. And we're now studying where I'm also, and I didn't mention the microbiome, which are all these microbes that live with you in your gut, in your lung, on your skin, in your nose, and all over your body, that those are important to maintaining health. And what happens is good bacteria go bad in the context of both COVID-19 and HIV. So we're now looking at how we can modify that. And my first meeting tomorrow is looking at the microbiome from our nose and what goes on in COVID-19. And I have a medical student working on that. So I'll be happy to come back and tell you what we find on my next talk.
Wonderful. We'll look forward to that. We have a question that says a lot of work has gone into getting vaccines to COVID available in less than a year. And this sort of touches on something that you mentioned. What work is going on to develop the therapies to treat the long haulers? And so what is that going to look like, do you think, over the next couple of years?
Yeah, great question. We're looking, if we believe that a lot of the long haul symptoms might be due to persistent inflammation, it's much like HIV. HIV in 2021 is controlled. The drugs work. Now, you have to be on the drugs for life. What persists? It's inflammation. So we're now looking at treating that inflammation. You know what we're going to be treating with? A drug some of you may actually have, metformin. It's a drug taken for diabetes. It's probably a drug that's been around 20, 25 years for diabetes. It's an anti-inflammatory. Not only does it treat diabetes, we're using it to treat HIV, and we're looking at it as a potential drug for treating the long haulers in COVID as well. So we think a lot of what's driving the COVID fog, the neurologic, the cardiovascular, the diabetes, metabolic, is persistent inflammation. So we're going to be looking at drugs, repurposing. And that's the whole thing, is we repurposed a lot of drugs to treat inflammation. You may have heard about IL-6 or IL-1. These are inflammatory mediators. But those drugs are really very toxic. So we want to get less toxic drugs. And we have a steroid, dexamethasone, that's been used to treat patients. It's changed the way COVID patients deal with. Those are steroids. And now we can keep patients out of the ICU today. Whereas at the first wave of the COVID-19, about 6-8 months ago, people were in the ICU and they were dying. Now, and we had at Rush, I didn't mention, we've evaluated 123,000 patients for COVID-19 at Rush. We've diagnosed 23,000. At the height of the COVID events back in March and April, we had over 300 people in the hospital. Our entire medicine division went to COVID. There were no endocrinologists, no cardiologists, no GI docs. They were all COVID docs. 600 people converted and pivoted to just do COVID work. Now, at the end, today, when we have this morning's census 64 patients, we're able to keep patients out of the ICU with drugs like dexamethasone and treating inflammation. So we think a lot of this might be where we're going to treat in the long haulers, and we're looking at that. One of the other events that occurs is coagulation. So we're now also treating, and we have studies with the NIH to treat the coagulation problems they have in the long hauler patients as well.
Thank you very much. We have another question. Let's see. Norma, I might have to have you ask this question yourself. I'm not sure I understand the question. Do you want to unmute yourself and just ask the question directly?
Okay, Alan, my question is, after you have been vaccinated twice, by having been given both shots, and waited 2, 3, 4 weeks even, your thoughts about going out to a restaurant, to a friend's house?
Yeah, I thought somebody would ask that question. I think we still, Deborah was discussing that when she could go. She's in the other room and she'll kill me because she's saying, when can the cleaning lady come in? When can I go get my hair done? Can I go in and shopping? And I think, you feel a little safer after your second vaccine, and I think that's fine. Let me just remind you, we're still recommending, even after being vaccinated, maintaining mitigation. So maintaining your masking, maintaining social distancing and hand washing. That's still part of the process, and that's important. I think, you know, if you have people in your house, you really want to know, I would still maintain that you don't want to have big gatherings, and that's not really warranted. But I think if you want to have a small, one or two close friends who've already been vaccinated, because you have to remember, Norma and others, that the vaccines, even the best Moderna and Pfizer, do not prevent infection. So people still can get the virus and shed it, although you don't develop disease. That's the point. So even, let's say you may, go to a restaurant and so on. So I'm still, I think being cautious is important, not going into big crowded situations. And I think a lot of people are even with the vaccines, we don't want to lower our guard. So I think just common sense, Norma, just, do things in a way that you feel comfortable and safe. And I think, you can do it with small gatherings, but wear your masks. I mean, of course, even if you're sitting in somebody's house, do you wear a mask? Just look, out of an abundance of caution,
right.
It's just important to do that because you don't want things to happen. You may not be the person getting any problems, but the person there you may transmit to if indeed you got exposed and you have the virus. So these things happen.
Well, I'd like to also comment that, the reason that we've been able to keep the preschool open is because of an abundance of caution and really just not letting ourselves get caught up in, the protection fatigue where you start to let things slip, and we're constantly reminding each other to do what we know we need to do in order to be careful. I want to ask one last question, if it's okay, and then if you don't mind, I would like you to share the story that you shared with me about your trip to NIH with Reagan and
Oh yeah,
C. Everett Koop. And then we can end on that story because that's funny. But the question that I had on one of the slides where it mentioned therapeutics, it actually shows those two drugs, the chloroquine and the hydroxychloroquine. And I wonder if you could just comment on, maybe put yourself into Dr. Fauci's shoes for a second and comment on sort of the process and how it broke down at that moment, and how the role of things like the FDA plays out in terms of the public correctly understanding what is and what isn't, and what to do and what not to.
Yeah. Well, bleach. Do not use bleach. That's my first recommendation, Charles. I know when well, no, I won't even say it in a joking way, when they took our president to Walter Reed, they took him first to the laundry, is where never mind. That was a joke somebody said on a call recently. But no, I understand what you're saying. I mean, these were drugs that were looked at and tried, and we went through the process. And I think, again, people like Dr. Fauci and others would say we need to go through the randomized trials. We need to show, we can try things, but if they're not controlled trials, we're not going to move them forward. And of course, that's what we did. We went through the controlled trials of treating patients with chloroquine and hydroxychloroquine. I mean, at the beginning, everybody was saying, I want to use it, but it did no good. It did no good for the patients. We found out it was not an effective therapy. The only thing that worked in those more severe patients, even the anti-IL-6 didn't work well. It was dexamethasone. That's been the great. So we went through clinical trials. Remdesivir is an antiviral that's been used. Again, we went through trials and we find it works, but it's not the best drug. So we're now combining it. So I think right now with the FDA, we're going through emergency use authorization. You hear all this all the time, EUA approval for drugs, for vaccines, but that means it hasn't gone through full FDA approval, full FDA vetting. I think now we're going to see more of that. Hopefully, as we improve on therapies, we improve on vaccines, we'll go through the full process. We need the EUA approval. We need to get out the drugs. We need to get out the vaccines as quickly as possible. But like everything else, we want to do no harm to the population. We don't want to get things out there that aren't going to do people good, or maybe do more harm than good, Charles. So I think ultimately we need to go through a process. We need to go through trials. I'm involved every day in many of these trials in finding new drugs, new opportunities. there is what's called Project Warp Speed. This is funded through Francis Collins, the director of NIH. They put billions of dollars into identifying new drugs, and we're treating patients with monoclonals, and we're treating patients with oral beta interferons to inhibit the virus or other viral, antiviral. So we're doing all those trials, both outpatient and inpatient, and we will go through those full vetting processes of showing the value of where those go. As you heard from Regeneron and drugs, those are the monoclonals that were given, and we're using all those drugs today, and they're having a tremendous effect. But let's face it, this is a global pandemic. We haven't even, there are 150 countries in the world who haven't even gotten their first vaccine, okay? Just remember how lucky we are living in the United States today and what we have in terms of a country, and we should be much further ahead in vaccination and protection here. But the rest of the world, it's really, it really just gets me every day. I look at it, how can we help and get this to the rest of the world?
Thank you very much for the wonderful discussion and the answers to all these great questions. And if you wouldn't mind sharing that story, and then we'll call it an afternoon.
Well, yeah, if people have other questions, I'm happy. But so anyways, yes, I'm at a meeting at Dartmouth with C. Everett Koop, who was the Surgeon General of the US. I wasn't actually, C. Everett was giving this talk, and he was recounting his days when he was with Ronald Reagan, the Surgeon General. And this was at a time when there was tremendous, HIV was not on Ronald Reagan's mind as supporting it. He wasn't necessarily our best supporter of the HIV/AIDS agenda. So C. Everett or Koop said, I'm at the NIH and we're walking down the hall. So he's there, next to him is Ronald Reagan, and behind them are all the Secret Service, of course. An alarm goes off. They then take Koop, C. Everett, and Ronald Reagan, and they push them into they open up literally a closet right there, push them into the closet. And in the next sentence, C. Everett says, I was the first one to come out of the closet with President Reagan. Which was a great line for a guy who had no understanding of the AIDS epidemic at all. So I thought that was just phenomenal to hear. C. Everett, he was just an amazing person in what he did in promoting this. Are there any other questions or thoughts? Happy to stay on a few minutes if others have anything.
So far we're getting Cindy Bernard has another one. She asks, how worried are you about global safety, including in the US, if we don't effectively vaccinate the entire world?
Yeah.
Well,
I you have to understand, beside the vaccine, you're also looking at natural infection. So I've said to you, as of this morning, 28 million people were infected in the US, 111 million worldwide. That's the stats of this morning. So part of what people talk about in terms of overall immunity comes from natural infection and vaccination. So as we're still looking at it, I think, we're a ways off, and I'm not saying we're going to be able to travel to some countries next week, but I feel, good about the US in terms of coming up in the next 6 months or so in travel. So I think things are going to get better as we roll out the vaccine. One of the questions that came up, I was listening to Michael Osterholm, who is a well-known person from Minnesota this morning on one of the talk shows, and saying, can we get away with 1 dose of vaccine? Now, of course, most people are still saying the EUA approval is 2. We need to look at that data. So that may be able to get us to a point where we could get everybody at least the 1 dose and show that they'd have effective immunity. And then from there, get them a 2nd dose, which can be delayed a bit. Again, full disclosure, I've had my 2 vaccines. I've had my antibody tested, and I do have good antibody. This is an N of 1, so it's not a huge experiment, Charles. I have good antibody against the spike protein after getting the Pfizer vaccine. So I think it's not a HIPAA violation if I'm revealing my own data.
We have two more questions that jumped up, and someone is asking about concern over what concerns do you have about long-term effects of the vaccine.
Mm.
Yeah.
I'm very comfortable having not seen, I've seen very little in looking at our own data. We're studying this long term. What I guess I haven't seen not a lot on allergic responses, and we're monitoring those quite a bit as well. So I think in terms of the RNA vaccine, the safety profile, I'm very comfortable with what I've seen of all the data, as well as the adeno vaccines, the AstraZeneca and the Johnson and Johnson. So I'm very comfortable with that. I think the one question, and we're doing the study now, is how long does immunity last? Now, again, full disclosure, I am over 65. Maybe I don't look it, but I am. No, I'm just kidding. But what I will say is my immune response was lower than somebody in the same who got the vaccine, and we looked at their data, who was in their 40s. So there is, again, as you're older, your vaccine, you're naturally, we know that as you age, you have lower immune responses. And again, even to this vaccine, you'll have a lower immune response. So the question is, what will I look like in my immune response in a year? I'm in a study in my own institution. We're studying 1,000 healthcare workers at 1 month, 3, 6, and 12 months post-vaccine, their second vaccine, to see what happens and how robust is that immunity. So my concern is what happens in a year from now. Are we going to have yearly vaccines? And how much are we going to have to modify to deal with the variants, like the UK variant, the Brazil variant, and the South Africa variant? All these are the key questions that we'll have to look at. The Moderna and the Pfizer look really good in terms of protection against those so far. AstraZeneca and the South African, as you know, they stopped the vaccine there in South Africa because of that. And I have to say, people haven't asked me today, but Israel's been a country that's been phenomenal in their response to COVID and getting and covering everybody with vaccine, and the studies that are coming out. Because I hear about Israel almost every day on the news. And I have to say, they've done a tremendous job of showing that robustness of antibody and what happens over time to immunity in their studies as a country.
It's good to be out in front in every way, shape, and
Every
form,
way,
right?
absolutely.
We have one last question, and it says the question is, how much do you trust the information coming out of China? So perhaps you can talk just a little bit about the relationship between the FDA, the NIH, the WHO, and all of these international organizations, and how we go about vetting information and making and how that translates into policy.
Great question. Yeah, that's really tough. I made my first trip to China October of 2019, so just before this all happened, and I was in Beijing and Shanghai and Nanjing. Yes, I could see what happens in China. I understand it is what the state is like there, having made my first trip with a colleague and so on. And you're right, the WHO went into Wuhan to look at that lab and to determine, where was the origin of this? Was it a lab virus? Was it from the wet markets of Wuhan? Was it a bat? Was it a pangolin? My favorite new animal. So if those of you who don't know, does everybody know what a pangolin is? Charles, you know what it is?
Yeah, it's been in the news with several of these outbreaks.
Yes. So those of you who don't know, you should look up and see what a pangolin is. It's one of my favorite new animals. And it was actually, again, fun fact, it was on the it was the world's most endangered mammal up until COVID, because the Chinese were eating it for lunch. Actually, it was on the menu at the wet markets. Plus, the scales were used for using medicinal purposes, anyways. But I think, overall, we're trying to understand and work together. But you're absolutely right. I think, the trust, we need to regain the trust with places like China, and we need to open up from the science perspective. I'm just saying, I think now, hopefully under a new administration in Washington, we'll have better relations and better interactions. I think the WHO, the NIH, the CDC, I think the leadership there is phenomenal in what they're doing and making us aware of everything and being open and honest about the global efforts here. And I think they've done a tremendous job. I think the new CDC director is phenomenal. Francis Collins, still the director of NIH, has done a phenomenal job. I think people like a voice like Tony Fauci on the chief physician for the US, a great person as well. So I think we have the right voices. I think we have the right leadership. I think we need to get back and deal politically now, maybe in a different era with China and hopefully open up those borders to understand more about what's going on in the future. So I'm not a politician, but I'll be an optimist on what could happen.
Okay. Good to hear. Good to hear. Well, I definitely speak for everyone when I say this was a wonderful, wonderful way to start off this series, and fantastic job that you've done. And thank you so much. And just, round of applause, even though it's virtual.
Thank you. Happy to come back with some new data and new information in a year from now when we.
That would be fantastic. That would be fantastic.
Thank you again. And thanks to everybody for staying on. It's been wonderful.
Yeah, and we had 26 people join us. So
it was wonderful.
Very nice turnout.
Great.
Thank you, Alan. It was great.
Thank you, Alan. That was wonderful.
Great. Very, very good.
Nathan
Very
made it.
There's your son, Alan. There's your son,
Thank you,
Nathan.
Alan.
Huh?
There's your son, Nathan.
I'm sorry about.
Nathan is there.
Oh yeah, no, I saw Nathan.
Oh, that was Nathan.
Nice to see you.
Nathan, can you put your video on so people can see you? Where are you?
Aha.
He was on.
There he is. There he is.
He was on for a while.
Nathan, where are you? Are you out in the field somewhere?
No,
He's in Scotland.
Oh, there's Nathan.
This is Ben.
No, there's Ben.
There's Ben.
Oh, there's Ben. Hello, Ben.
Hello, Ben.
Nathan.
All right. Thank you all for
Thank
joining
you.
us.
Thank you.
There's Nathan.
The initial announcement said we're going to have this every week. We're actually going to do it every other week. So the next talk will be March 7th, and our member Jackson Cohn is going to talk about his work in neuroscience. So we're all very excited to look forward to that. And again, thank you, Alan, for a fantastic afternoon.
Yeah.
Thanks, Charles, and thanks everybody for staying on, and thanks for the questions. I am really, it's amazing to hear. I have to say to the audience, the questions were insightful. They were straight, they were spot on, and really phenomenal. So I really thank you for your questions and your thoughts. And if any of you, and Charles, if anybody has any questions or anything, please, they can always email me and I'm happy to talk.
They can send them to me in the office and I will forward them.
Thank you again. Bye-bye.
Fantastic. All right. Have a good afternoon, everyone.
You too.
Thank you.
Be healthy.
Thank you. Thank you.
Bye.
Everybody
Bye-bye.
have a
Thank you so much.
good day. Bye-bye. Bye-bye. Thanks.